All right, welcome everyone. This is Yasmina Sisarak. Welcome to our second webinar in a Healthy Brain webinar series. Healthy Brain webinar series is presented by the HealthMatters program at the Department of Disability and Human Development at the University of Illinois at Chicago in partnership with National Task Group on Intellectual Disabilities and Dementia Practices, and is funded by the Centers for Disease Control and Prevention, National Center for Chronic Disease Prevention and Health Promotion, Healthy Brain Initiative. Contents are solely responsibility of the authors and the presenters and do not represent the official views of the CDC. Just a little bit of housekeeping for today before I introduce our presenter. Continuing education credits are not offered for this webinar. Each live webinar will be recorded and we will make the recording available on YouTube. You will be emailed once that is up, and we usually do it in about a week or so. And please use chat box for comments and questions. We have about 400 attendees that have registered for this webinar, so it's a large group today. And without further ado, I wanted to introduce Lucille Esralew. And Lucille will be talking about brain health across the lifespan for people with intellectual and developmental disabilities. And just a little bit about the presentation. This webinar will present best practice and policies that can support healthy habits for brain health among people with intellectual disabilities across the lifespan. Dr. Esralew will discuss what we know about the trajectory of healthy brain aging for people with intellectual disabilities and how good brain health can help people realize their abilities and optimize their cognitive, emotional, psychological, and behavioral functioning to cope with life situations. Considerations about aging with the disability and with dementia will be discussed. Lucy, welcome.
Well, thank you, Yasmina, for the introduction. Hello, everybody, and just a little bit about me. I am currently serving as senior psychologist for the California Department of Developmental Services. But the bulk of my presentation today will be more linked to my work through the National Task Group on Intellectual Disabilities and Dementia Practices, NTG. I am on the board of NTG and serve as chair of the NTG Scientific Research Consultative Panel, and I co-chair, along with Kathy Bishop, the NTG Advisory Body. So just a disclaimer before I begin, that the views expressed in this presentation are strictly those of, they're my views, and do not reflect any official position of the California Department of Developmental Services. And again, you will hear a lot that has been tied to my work over the past almost 11 years with the NTG, and particularly about the NTG-EDSD, the early detection screen for dementia. So, sorry about that. And so what are our objectives for today's presentation? Well, I'd like to consider with you some strategies that support brain health for people with intellectual and developmental disabilities across their lifespan, and use the framework of the 6 pillars of health to further that discussion. And of course, have the opportunity to introduce you to the National Task Group Early Detection Screen for Dementia, the NTG-EDSD, and make a case for its use for adults age 35 plus as a tool for health promotion, advocacy, and shared decision-making. So the good news is, though we can't cure age-related cognitive and adaptive changes, there's a great deal that we can do to reduce the risk of decline as we age. Many of the health conditions are related to health lifestyle choices that put us most at risk for poor health, cognitive and functional decline as we age, and are modifiable. And one of the takeaways from this slide in particular, I want you to keep in mind, is to age in a healthy way is the equivalent of having cognitive health. They are interchangeable in terms of ideas. The same thing we can do for persons without disability, we can do for persons with disabilities. So aging is a lifelong process. Those of us who've been trained as gerontologists, and that's where I got my beginning in my career. I was trained as a gerontologist and geropsychologist, recognize that aging begins at birth, and that a lot of the good things that we can say about aging has to do with, the influence of early childhood and early and middle adulthood. So the message here is, as soon as we can pay attention to healthy lifestyle choices, and we can begin this immediately as soon as possible, the better off we're all going to be as we age, including the individuals whom we support, the persons served. We want to pay attention to regular and routine health care and pay particular attention to exercise, nutrition, management of stress level, relationships, and meaningful activity. We're going to have a little bit more to say about that later in the presentation. But one thing we also want to pay attention to is the tendency that we have by middle age of developing chronic medical conditions that can very much impact on our overall cognitive and functional status as we age. So that's true for all of us, and it is particularly true for older adults with disabilities, although they may need to pay attention to chronic medical conditions earlier than the non-disabled population. So we also want to pay attention to sensory processing issues, because what the information we get from our senses are what helps us all with adaptive functioning. And very often the value of hearing and compensating for poor hearing, or visual problems and compensating for poor vision, or problems with movement and paying attention to that. By overlooking these important sensory processing issues, we undercut the overall adaptive functioning of people as they age with disabilities. So there's certain expected physical changes with aging that we can all expect. Bone loss, change in muscle mass, the lenses of our eyes become stiffer and less flexible, so we are less able to accommodate close objects. We have age-related changes in our hearing, age-related changes in our sense of taste and olfaction. We have reduced sensitivity to pain, touch, temperature, and proprioception. And we have the possibilities of reduction in balance and coordination. We also have the direct cognitive changes of reduction of short-term memory, problems tracking and paying attention to things. Where did I put my keys after all? Where is my wallet? And that retrieval of learned information, although not necessarily forgotten, may be difficult to retrieve. It may require more effort when it was much more automatic when we were younger. And in general, we just change in our processing speed of information. We all slow down. So that's true for all of us, whether we have disabilities going into aging or not. But there are particular concerns that we have for individuals who are aging with intellectual and developmental disabilities. We know there's a higher incidence of medical conditions and mental health disorders that may accompany aging with intellectual and developmental disabilities. Just as a group, although the group of individuals with IDD is a heterogeneous group, there is on average more likelihood of accompanying medical conditions and mental health disorders. And then we also have the idea of the cumulative effects of these chronic health conditions, medical as well as mental health, and decades of therapeutics, the medications that people may be taking in order to address these conditions. So individuals with IDD are more likely to experience such things as aspiration, dehydration, constipation, sensory processing issues. Often these things, which are not necessarily debilitating in and of themselves, may go for the individuals for whom we're interested in thinking about, go undetected and untreated at onset, and thereby become more problematic and contribute to declines in cognitive and overall functional status. We know that many individuals with IDD are at higher risk for falls compared to their same age peers, their chronological peers without disabilities, because of the heightened risks attributed to seizure disorder, to the idea that if one takes 4 or more medications, that is likely to be associated with a higher risk of falls. The fact that they may be dependent upon or utilize assistive devices in order to be mobile or have other physical limitations, all increase risks for this population for falling and having gait problems as they age. And we know that life expectancy for persons with IDD, although it's getting to be longer and longer, certainly it's no longer the case that the average age of a person with intellectual or developmental disabilities is 35, where it was once the case. Still, it is generally lower than the non-disabled population. And we have a sense that individuals with intellectual and developmental disabilities may actually age earlier, and I put that in quotes, than the individuals without disabilities. Individuals may not be diagnosed or treated for their medical or mental health conditions by virtue of the lack of access to medical and psychiatric services that would otherwise be appropriate for them, but because of disparity in care systems, they may experience that they're not getting the care that they need. So in particular, we do have a series of genetic and neurodevelopmental disorders that have their own aging trajectory. And we're learning a lot more about this as we have population of individuals with these disorders who are living to older ages. So probably the group that we know most about are individuals with Down syndrome. We know, for instance, that there is an association with early onset dementia, meaning that individuals with Down syndrome, trisomy 21, and because of the accumulation of beta amyloids, which have to do with Alzheimer pathology, that they're just more likely to show signs of cognitive changes related to Alzheimer's and other neurocognitive disorders around the age of 50 or so. 55 may be the average age in which we may begin to see significant change. Individuals with Down syndrome may also experience cardiac, thyroid issues, and sleep apnea, which will have long-term implications for their brain health. So again, there's something particular about having Down syndrome, trisomy 21, which might influence the trajectory of aging for these individuals. We know that cerebral palsy can be associated with progressive changes in muscle tone. Individuals who are older with cerebral palsy may have swallowing difficulties, dysphagia, and there may be changes in pain level, all that impact their overall functioning as they age. Individuals with Prader-Willi can experience higher rates of cardiovascular disease and diabetes, both of which have implications for brain health. As well as there have been reports that individuals with Prader-Willi as they age may be more prone to psychotic disorders as they age. Adults with Fragile X may have more issues with heart problems and musculoskeletal issues. And as sensory processing issues that we mentioned before may go unrecognized or untreated, contributing to the person's overall decrease in adaptive behavior or cognitive functioning. Because after all, it is through our senses that we get information about our world and helps us in making adaptive changes to meet the needs of whatever might come up. Individuals with IDD are thought to carry a higher risk for mental health conditions than their non-disabled peers and are more likely to require medication management. And that is when we compare individuals with IDD with their same age peers without disability. So we can't, in the context in which we're in and the time we're in, forget about COVID-19. And that itself has taken a toll on the brain health of people as they age with intellectual and developmental disabilities. We've heard about an increase in reports of loneliness connected with COVID restrictions, such as quarantining and social distancing. We're still learning about the brain health effects of COVID just as a neurological phenomenon on the overall cognitive functioning for people who are termed long haulers. But also, might there be some distal effects for those who've seemingly recovered from COVID, are not particularly showing anything right now of concern, but may show some signs and symptoms connected 10 or more years down the line. And just as an aside of that, I had been doing some reading about the effects of the Spanish flu of 1918. And there they found that when individuals born in 1919 who had been exposed to the Spanish flu later turned 60, when that cohort turned 60, they were at higher risk for both cognitive issues as well as cardiac issues. And researchers at UC Davis were able to make a link between their exposure in 1919 as being born at that time and decades later effect on their health. That's what we mean by what might be the distal effects. And individuals who've been at a risk for heightened stress due to the loss of loved ones, maybe even their own experience of having COVID, a disruption in their care routines, reduction in their access to community activities and programming, and just general disruption of their support and social networks. So in that context, just so you to know, for you to know that loneliness is considered a very significant health risk. It is both a physical and mental health risk. So social isolation is viewed as a factor for premature death, a risk factor on the order of cigarette smoking, physical inactivity, and obesity. Without social connection and meaningful activity, cognitive and functional status may decline. Even the least social among us is a social being. We're hardwired for social connection. Okay, so loneliness and isolation can have serious health consequences. Research has shown that people who feel lonely or isolated are at increased risk for developing coronary artery disease, stroke, depression, high blood pressure, declining thinking skills, and inability to perform daily living tasks, or even premature death. So, of course, this has health and brain health significance. So what does health maintenance look like? Well, wellness checkups, immunizations for individuals who are known to have neurodevelopmental conditions that have particular medical or mental health consequences. They should have those conditions monitored as they're aging. Age and gender relevant health screenings such as diabetes, cholesterol, cervical, breast cancer for screening for women, prostate exams for males, colorectal cancer, osteoporosis, depression and suicide risk, and cognitive screening for adults. And I would lower the age, although we tend to think of it as for 65 and older. I would lower the age for individuals with intellectual and developmental disability and begin it no later than age 50. And we'll talk more about that when we look at the NTG-EDSD. So there are 10 health risks that impact wellness. I'm sure we could come up with additional ones, but these are the main things that we key upon when we think about lifestyle and how to alter it to support better brain health. Tobacco usage, high blood pressure, stressful living, lack of physical activity, being overweight or obese, poor diet, home safety, lack of personal care, lack of social connection, and lack of mental stimulation. So those are among the things that we key on. And the Healthy Brain Initiative, which I believe the participants in today's webinar are interested in, really do key on factors such as this in order to think about how to promote healthy aging. So we talk about the 6 pillars for healthy brain health. And I just want to spend a few minutes with all of you in considering this. And this is the attention to exercise, nutrition, sleep, mental stimulation, and social connection that we will all benefit from, not just people whom we may support with an intellectual and developmental disability. So it's never too late to start exercising, which I remind myself every morning. It's a great way to improve health, physical functioning, and well-being. And among the reported benefits is improved strength and mobility, improved balance, which will help prevent falls, improved mood, decrease in fatigue, lowering blood pressure and cholesterol, improved self-esteem, increase of clarity of thinking, and it can improve sleep, prevent weight gain, and improve bowel and bladder functioning. So it may not cure all that ails you, but it does cover quite a list. And so physical activity is something that we want to promote. We also want to promote healthy eating. And what I did was pull up a poster that summarizes some of the foods, the best foods for the blue zone. Blue zones are places around the world where it has been noted that people have lived past 100, higher percentage of people who've lived past 100 in good health. And so some of the learning that we've done involves the food that has sustained healthy living, brain health, and overall cognitive functioning. So it is mainly a plant-based diet with small portions of meat. I'm sorry for those of us who like meat, but indeed, it turns out it's healthier to rely on plants. A moderate consumption of fish, mainly because of pesticides. Avoiding cow's milk, which may seem counterintuitive to those of us who were bred up with this idea that you should be drinking milk on a regular basis. Eating a cup of beans daily, limiting your sugar, perhaps substituting honey, eating a handful of nuts as a source of protein that is non-meat, eating 100% whole grain breads, and eat whole foods or ones with fewer than 5 ingredients, and drink when you're drinking mostly water. So there were other things that people have learned in studying people who live to 100 or beyond in these blue zones that do not necessarily focus only on diet. We've learned that people who live in these areas do a lot of moving. They don't necessarily join gyms or have expensive exercise equipment. They walk, they garden, they move naturally. They have a purpose for waking up each day. They have routines that help them deal with the stress in their lives. They stop eating when they're almost full, 80%, and eat the smallest meal of the day at the end of the day. They may drink wine, but it is in moderation. They often belong to faith-based community, whatever that might be for them. They put families first, and they belong to social circles that support healthy behaviors. So one of the ways to reinforce a healthy lifestyle is by joining with others who also share that value. So sleep is one of the 6 pillars that we should pay attention to. And by the way, we should be doing this throughout our lives. At different points of our lives, we may be putting different emphasis in any of, whether it's the foods we eat or the amount of sleep we need, etc. But this still remains a factor that's important for brain health, regardless of your age. So sleep changes occur naturally after age 60. There's a shift in hormone and melatonin levels that may cause us to take longer to fall asleep, sleep more lightly, and wake up more often during the night. Lack of sleep is not to be taken lightly. It has been associated with a compromised immune system. It can affect our ability to pursue daily activities. You will see individuals who are increasingly confused if they don't get sufficient sleep. It can affect our mood and concentration and may contribute to falls. It's vital to good health, as important as good nutrition, regular exercise, and positive attitude. So if somebody's not sleeping soundly, that person should consult with his or her doctor. One of the things we have found is individuals with Down syndrome are particularly susceptible to sleep apnea because of the structure of their faces, which lead to a little bit more obstruction in the nasal cavity. So it may be important for people to have that checked out. They've had big changes in how they approach improving sleep. You no longer have to wear a mask that makes you look with a CPAP machine like Darth Vader. So it's very important to get this checked out. So it may also help to have a more consistent sleep routine, go to bed the same time every night and wake up at the same time every morning, fall asleep in the same position. Most of us have a typical position that we fall asleep and stay asleep in. Maybe a cup of warm milk or herbal tea before bedtime, a warm soak in a tub, and certainly to address snoring issues. That's what we mean in terms of the sleep apnea or the possibility of that. Yeah. One of the biggest things for us to continue doing, and that's even when individuals who we're supporting may show cognitive decline that we might suspect is associated with Alzheimer's or other neurocognitive disorders. It is always, our brains are designed to be stimulated. And we need to keep this as a lifelong pursuit. So staying mentally active enriches our lives. It not only reduces boredom, it can confer a sense of purpose and accomplishment. All these things are good for cognitive health, brain health. So mental stimulation does not have to be classroom or based or within the context of academic setting. Anything that you learn that is new is mentally stimulating potentially. You can learn a new hobby, to do puzzles, a new recipe, watch an educational TV show, learn to play an instrument, learn a new song. Any of these things and more can be stimulating and worthwhile and contribute to brain health. The other thing I've mentioned a couple of times is the idea of handling stress. When we are stressed, we react physiologically. We secrete hormones when under stress that have a stronger impact on aging brains. So challenging ourselves to recover from an emotional upset might take a little bit longer. Take change slowly and learn ways to cope with anxiety or tension. And with the individuals whom we support, helping them find ways to relax, maybe engaging in mindfulness exercises, maybe by communing with nature, by nature walks, or deep breathing, or just slowing things down and learning how to be positive. These are all coping skills that we can work with individuals with intellectual and developmental disability, their families and staff to develop, and will have beneficial impact on brain health. Social connection, staying socially active. Now, I know we've been particularly challenged during COVID to do that, and I know that people are, many of them, anxious to get back to program, get back to work, get back to community activities, get back to visiting family and celebrating rituals like graduations and birthdays, or participating in, weddings or funerals, or, any of the things that sustain us socially. Again, very, very important for our health, both physical and mental, for the reasons that I had outlined before. So I'm going to really use some of the remaining time, because I'd like to have time to actually answer some questions, to introduce the NTG-EDSD, the National Task Group Early Detection Screen for Dementia, and just say that it came out of our recognition at the NTG. Clinicians were reporting that persons with IDD were not being brought to the attention of healthcare providers until their cognitive changes and adaptive changes were well advanced into the change process. And we thought we need a way to capture information about change that families were observing, that staff were observing, that maybe even clients themselves were observing about themselves, and find a way to share that with healthcare providers in order to move their healthcare in the right direction. For those eligible, by the way, the NTG-EDSD could be used as part of the annual wellness visit, paralleling the screening done for individuals without disabilities after the age of 65. So there's a practical utility of this screening tool. It provides family and professional caregivers with a tool to capture information about changes in cognition, behavior, and functioning. It provides the caregivers with a format to share information and begin a dialogue with the consumer's healthcare practitioner. The categories on the tool promote paying attention to the areas of significant change, thereby helping family members and professional caregivers become better at observing and reporting relevant signs and symptoms of functional change. So this is what the cover page of the NTG-EDSD looks like. It's the early detection screen from dementia. It was adapted from the dementia screening questionnaire for individuals with intellectual disabilities, developed by Dr. Shamitra Deb, British psychiatrist, and others in 2007. And that tool was adapted by the Philadelphia Coordinated Healthcare Group in 2010 into a dementia screening tool. And indeed, we based our work on both of those items which preceded our tool. Thank you for posting the web link for that. So we recommend that individuals with Down syndrome who are known to manifest signs of early onset dementia in their 50s, that you begin using this tool, and the you being family or staff or staff as early as age 35, but not later than age 40. And then done annually until, the team reaches some direction about what's happening for the individual. For those without Down syndrome, you might begin when changes become noted or after the age of 50. We don't have any evidence that individuals without Down syndrome necessarily develop signs of neurocognitive disorder at the same time as those with Down syndrome. We piloted it in 2012, and it's been used internationally. The role of the family and staff. The family and staff are raters for the NTG-EDSD, and staff need to work with the individual for at least 6 months in order to serve as a rater in this instrument. Staff are more likely to be aware of subtle changes in behavior and functioning that may signal important information for healthcare providers than the provider who may know the consumer for a long time, but only has a really limited exposure to them once or so a year. So we wanted to make sure that all the information that is captured by the people who know the individual most closely could be shared with the healthcare provider. So how is it connected to health promotion? By identifying areas of early change, the interdisciplinary team can refer for further targeted evaluation. So by identifying areas of early change, the team can plan targeted supports and services, accommodation of existing services, and equip the client, the family, and staff with training and relevant resources. By identifying areas of early change, the IDT can obtain valuable information about contributions to change in cognition, behavior, or adaptive functioning. And there are questions on it that ask about sensory status, mental health, management of chronic illness, and about pain. So therefore, because it's an administrative rating tool, it can be used as a basis for shared decision-making. It is not a diagnostic tool. Again, it's there to capture observations of change that are had by the people who work most closely with the individual. The tool is used to promote discussion within the team regarding possible ways of addressing observed change, and to promote discussion among DSPs, family members, and healthcare providers that can result in shared decision-making. Again, it looks at domains of behavior, personality, memory, activities of daily living, and sleep, among others. So you look for patterns when you're looking at the ratings from the EDSD. What are areas in which change has been noted? To what extent has the change occurred? Is there something being done to currently address the identified issues? And all this information is shared with the team, the interdisciplinary team. Then we could reconcile discrepancies across settings, because people may observe something in a residence and there may be different observations in the person's program or work site. Then it also allows the team to say, where do we need more information? And from whom should we request additional information, or is additional observation needed? And you can engage in brainstorming and operationalize a plan of action and develop the criteria to determine effectiveness of your plans of service and care. So there are a number of decisions that may follow from ratings that you have from the EDSD. You may decide it's important to modify the residence for the individual, or maybe even change the person's residence. Perhaps there are implications for staffing support, where the ratio of staff to the client is not sufficient for supervision and safety purposes. You may want to change programming because you come to a realization that current program demands are beyond the expectations that are reasonable for the person at this point in time. You might develop a different positive daily routine and identify items and actions, activities that are stimulating for the person, that are within the person's capability. So if a person has declined in their activities of daily living, it can affect the level of care support, how you deploy staff. It may mean you want to make changes in the physical setting in which the person is supported, and that there may need to be consideration about supplies and equipment the person may need. Remember that if indeed the person has a neurocognitive disorder like Alzheimer's, this is a progressive, changing, evolving situation that will require tracking how the person is doing. So using the tool can promote time-sensitive interventions and support. I'm going to share findings from the EDSD with healthcare providers so that the healthcare provider knows about the person's daily functioning, advance the conversation leading to possible further assessment or diagnosis, and get the most out of the visit with the healthcare provider. And you utilize the tool to identify, advocate, and promote the healthcare needs of the person with IDD. What types, if any, of visual and verbal cueing benefit the person? Would role modeling or other supports help the individual remain as independent as possible for as long as possible? Because, we hope people can age in place with the right kind of supports. What does the person need in order to be safe? What areas may need follow-up for optimal health? Does the person need some assistive devices? Do they need something for their sensory losses, pain management? Do they need mental or social stimulation? What does the person need in order to be comfortable? What does the person need in order to have the best quality of life as defined by that person and those who support that person? So again, the tool is not used for diagnosis of dementia. It is an administrative and not a clinical rating tool. The diagnosis of neurocognitive disorder involves a medical exam and direct cognitive and adaptive testing of the individuals in question. If anybody purports, or claims that they can tell that somebody has dementia by just, asking some questions or looking at them, I would be highly suspicious of that. If the consumer is already known to have dementia, use the rating form to baseline observation of functioning, and then, then that could help the team in making some decisions about changes that need to be made in supports. Since this is an early screening tool, it's not necessary to continue using it if the person is already diagnosed with a dementia, another, neurocognitive disorder like Alzheimer's or a related disorder. So within this past 45 minutes, I've laid out some of my thoughts about brain health, and we've ended up on a little tour through the NTG-EDSD, but I want to end on some notes about health promotion and advocacy for persons with IDD. So one thing we know is individuals with intellectual developmental disability are disadvantaged. There is not parity, there is disparity in healthcare in terms of their access. So we want to advocate for parity of medical and mental health services for persons aging with intellectual and developmental disability. That means access to diagnostic assessment, to treatment, to rehabilitation where that is relevant, and for health monitoring. We want to reconsider service and programmatic designs and environments that will promote independence within the person's capability. And indeed, we think about aging in place as being a very worthwhile goal. We want to educate all stakeholders about the relevant issues and local resources for individuals aging with disabilities. And very often family members or staff just don't know what's available out there for their members, for their consumers, clients who have who are aging with disability. Want to encourage cross-training, and I think this is very productive, and we've been doing this for a while, to build capacity and maximize resources for both the aging and disability communities. So there's a lot that the aging community can tell us about supporting individuals with disability as they age. And I think there's a lot we can do to contribute to the aging community to help them understand the particular needs or special needs of people who are aging with disability. We have to recognize aging is a highly diverse process that probably begins much earlier for persons with intellectual developmental disability than for individuals without disability, and that chronological age may not be the best indicator of health status for people with intellectual and developmental disability. Individuals with IDD age with disability, but they also age into disability. So people with IDD may age into dementia or additional physical limitations or sensory processing issues that they did not have at a younger age. And all this kind of compounds the challenges that any individual might face. How can we best support the person who is aging with and aging into disability? Want to place a greater emphasis on health promotion and maintenance, build upon what we have learned about hybrid models of health provision that can benefit older adults with IDD. And I have a question mark there because we're still in the process of learning about how we use both technology and in-person support to maximize services and programming and care for people with IDD. And when do we begin paying attention to aging with IDD? Well, we begin paying attention to it now, at whatever age the person is, because the aging is a lifelong process, as is their aging with disability. So I want to thank you. That is what my thoughts are about this topic today. Here are some references, and that's me. So I'm open for questions at this point in time.
Thank you so much, Lucy. Please put it in the chat box if you have any questions. We have a large group, so we will not be opening it up to verbal questions. We did have one question come through. Does NTG recommend the EDSD as a baseline tool or only after changes have been noted?
As a baseline, yeah, that's a great question. And we recommend it as a baseline tool. And that, and this way you can, really the whole idea of change is change from what? Change from some characteristic or typical baseline for the individual. So you're in the best position if you use the tool, early on enough that you can get a baseline before any changes occur.
What is your role in California Department of Developmental Services, and what and how brain health strategies could be addressed?
Okay, well, again, when it comes to policy, I am, that is handled at a different level. I'm senior psychologist operating out of Sacramento and assigned to the Office of Statewide Clinical Services, the Clinical Services branch. So, what I do currently is just educate about the Healthy Brain Initiative. What does that look like? How can we incorporate that in our thinking?
What types of brain health strategies would be helpful to improve outcomes related to work, socialization, community involvement, etc.?
Okay. Well, that's a big one, but so let me take that. So anything that enhances, so most things, I think, this is my personal opinion, are done through relationship. Most things that are effective for individuals whom we support are effective within the context of relationship. So whatever strategies build relationships at work or in the person's various setting is how you get the most productive outcome. We are socially wired. We are hardwired to be social and connected. Some of the individuals whom we support have some challenges with regards to that and need our assistance, particularly during these times when they don't have the regular access to their support network. For us to be very purposeful and thoughtful in how we keep people in connection with one another until they're able to see people in person. How do we keep them connected via phone or via Zoom or Skype? Or arrange for various rituals having to do with people's lives, help them remain in contact with their family, help them build a sense of community where they are. So again, we will hopefully be, at a point where we're seeing one another again and we're able to be in person contact again, and that will be great for us. So, I see a question about what are some of the easy reach things. So some of the easy reach things about promoting the Healthy Brain Initiative is by offering exercise classes or building in, walking groups or gentle yoga or a variety of physical activities into the person's daily routine and giving them opportunities for that. Offering classes on healthy eating, involving people in meal preparation, in which, really the goal might be to increase the number of fruits and vegetables, shopping at the farmer's market, or looking at what food choices might be the best food choices, what snack choices, involving people in menu planning for themselves. Looking at sleep hygiene routines for people. What are ways that we can optimize their ability to fall asleep and stay asleep and have a good night's sleep that's restful and restorative for them? Promoting activities that, that are opportunities for people to get together in one way or another. So, I think these are all ways in which agencies can, within their programming, offer opportunities for healthy life choices, recognizing that not everybody is going to be taking or signing on to them right away, but at least beginning to encourage and to promote those kind of healthy brain activities.
Thank you, Lucy. And it's important to note also that with our Healthy Brain Initiative, we will be sort of compiling some of these easy reach, items and things that organizations can utilize with very little energy. With that, there's another question about what resources are available to regional center consumers who may need a diagnosis for possible dementia.
Well, so the place to usually start is with the person's provider, healthcare provider. And then in many of the communities, there are places in which there are dementia clinics or clinics in which you can get an evaluation. So it really depends on where you are. I would always recommend starting with the person's PCP. And by using the National Task Group early detection, screen for dementia, that is one way of facilitating this conversation. We've noticed some changes. We would like to better understand what's going on. And I think that it's very often the case that the PCP might be able to help direct that connection to places that are available for evaluation. The evaluation is a comprehensive one. So it's not one test and you're diagnosed. A real workup is a comprehensive, extensive, involving lab values, a direct assessment of the individual, where the individual is given tasks to do, and you see where they are performing and they're functioning. So it's time consuming and is pretty extensive. But the best place to begin is with the family practitioner or the primary care practitioner.
Thank you, Lucy. There's always a little bit of a confusion between brain health versus dementia care. Can you speak to the difference between brain health versus dementia care?
Right. So brain health is for everybody at all ages. So I think that as you are, whether you're a child or whether you're an adolescent or a young adult or middle-aged adult or an older adult, the time to be paying attention to your brain health is now. And that's true for us, and it's true for the people whom we support. And that is because what we do now will affect us later in terms of our brain health, and the brain requires certain maintenance. And that looks to be along the lines of our healthy choices. So along that list that I gave you about things that we want to control and things that we want to reduce, and, so social connection, stress management, all those things are things that could be begun at a fairly early age, nutrition, etc. Dementia care is when we really recognize that there is a segment of the population that as they age have acquired neurocognitive disorder. And by the way, we still need to engage in brain health activities and practices, even if somebody has a diagnosis of dementia. We're not going to give up on what is best for the brain, even when we acknowledge that the person may have a neurocognitive disorder. So dementia care is specialized care for individuals who are known to have either Alzheimer's or another neurocognitive disorder, but brain health is for everybody at all stages.
Thank you, Lucy. That I always feel like this is a very important sort of division of the meaning, because people would always, oftentimes people assume that individuals with intellectual disabilities, their lifespan trajectory is the end result is dementia. So it's kind of important to talk about that. One last question. We have 1 minute left. What are your recommendations, or how can individual providers include brain health across the lifespan? For example, in primary care, psychologists, nurses, case managers, and even thinking about community-based service providers.
Well, I mean, I think that the idea of lifestyle choices cuts across different disciplines and domains and activities. And if we just kind of engage in this pursuit of, there are certain choices that are better for us, and there are certain choices that are not. So for instance, an emphasis on exercise or physical fitness or just being active. And if you'll notice that some of the campaigns lately really just focus on being active, like they want to take the idea of exercise out of it, because people may have an allergic reaction to the word exercise. But in fact, that's something that can be promoted at the very beginning. You know, you start walking, you know, for those individuals who are capable of walking. For those people who are not capable of walking, you go outside. You can engage in various stretching activities. There are dance, there are wheelchair dances. There are yoga moves that can be done from a seated position that do not require getting into a pretzel. So there are many ways that we can promote the value of activity in whatever domain that we're in. And stress management, the idea that people can learn within.
Whoops, I'm not sure if we lost Lucy. Oh, I think we lost Lucy. Thank you very much for all of you who hung with us for additional couple of minutes. We will provide you a recording and the PowerPoints in our YouTube channel. You will be emailed within a week with archived link. Please join us on June. I'm sorry, Lucy. I felt like we lost you.
Okay, yeah, so I just came back, so I don't know at what point I left off here, but all of a sudden I got this menacing notification that I was not connected. And since I value social connection and internet connection, both very much, that was very distressing to me. So I engaged in a little bit of mindfulness practice here.
I was just thanking everyone and announcing the third webinar, which will be expanding on what you touched upon today a little bit about nutrition and brain health for people with intellectual and developmental disabilities. Lucy, thank you so much. There are so many amazing, so much amazing information, and just the beginning to kind of expand on everything that you touched upon.
Well,
thank you so much.
Thank you for the opportunity.
We'll stick around for a few more minutes to see if there are any other questions. Otherwise, thank you for attending and have a great rest of the day.